want to welcome you to ACEP's Open Forum this afternoon. We are so grateful that you're here and participating. My name is Jana Nelson. I am the SVP of Communication for ACEP, and I just want to introduce you to our brilliant President-elect, Dr. Aisha Terry. Take it away.
Well, thank you so much, Jana. I really appreciate that introduction, and it is a pleasure to be with all of you today. First of all, I want to thank you all for taking time out of your busy schedules to be here. I want to thank my illustrious co-panelists, whom I will introduce shortly, for joining me. And certainly I have to recognize and thank ACEP staff who work tirelessly behind the scenes to make the magic happen, I promise you. And so thank you all so much for all that you're doing to contribute to this session. So welcome to ACEP's Open Forum. This is an opportunity to hear from you on topics that are vital to our specialty and to our profession, and most certainly vital to our patients. Here we are midway through June 2023, hopefully with the pandemic behind us and looking forward to the future. But the reality is that we are still facing, as a specialty and even as a profession in medicine, several challenges, certainly as we go forward. Everything from burnout to boarding, reimbursement cuts to corporatization and consolidation, workplace violence to scope of practice creep. And what exactly happened with the match this year? Can we talk about that a little bit? So what's going on? And more specifically, what has ACEP done to safeguard the autonomy of the emergency physician and to advance the specialty for a brighter future? The brighter future that we so desperately need, really, as the safety net of healthcare, caring for the millions and millions of patients that we see every day in our emergency departments. Well, I'm glad you want to know, because I want to know as well. And that's what we're here to talk about today. And before I actually introduce my co-panelists, I just want to share a little bit of my perspective in terms of, from the president-elect seat of ACEP, kind of what ACEP is doing around some of these key issues. I can tell you that just in the past 3 days, I've been in 3 very important meetings wherein ACEP was at the table and taking the lead on really important issues. I was in Chicago this week at the annual AMA meeting, where emergency medicine really crushed it, honestly, in terms of accomplishing many really important resolutions and getting them passed in the House of Delegates. Everything from basically recognizing EMS, or emergency medical services, as essential. That is now a resolution in writing. And also from having had very successful elections, we now have increased representation in the AMA, in the House of Medicine, from emergency medicine. And that all happened just this week in Chicago at AMA. I also had the pleasure on, I think it was Saturday at AMA, of serving on a panel and representing ACEP and emergency medicine on the topic of private equity and corporatization. We certainly are not the only specialty that is facing challenges and opportunities related to really how the market is moving in terms of consolidation and corporatization, which are not the same things. But essentially on that panel, I talked a bit about how emergency medicine is particularly vulnerable, actually, when it comes to corporatization and consolidation, because one, many of us are not employees, but rather contractors. And some of us are employed by the hospital, for example, which actually sets us up to be vulnerable to both vertical and horizontal consolidation and the effects therein. We actually at ACEP had the opportunity to speak with the Federal Trade Commission about a year ago. They actually approached ACEP to learn more about where things stand in terms of physician experiences when under the influence of consolidation or corporatization and maybe even private equity. And so we actually had a listening session with the FTC, as well as the antitrust division of the Department of Justice. And they wanted to know what is happening on the ground and how it's impacting our day-to-day practice and ability to care for patients. We actually surveyed our members even to get more information. And what we found is that when it comes to autonomy, due process, being able to find employment, when it comes to things like feeling like you wouldn't be really held accountable for any whistleblower type action. That many members from this survey actually felt that generally they had really had worsened experiences relative to corporatization and consolidation. And so that's what we're here to talk about, these things that are impacting our practice, these things that are impacting the environment that no doubt leads to increasing burnout and the like, and how we together as a specialty, and certainly being led by your specialty organization, can address some of these matters. So with that, despite all of the challenges, I can tell you that I feel confident and I'm very hopeful for the future. I do believe that we are going to be just fine. And in part, that confidence is because I have colleagues by my side, like the illustrious Drs. Corker and Dr. Ruzek, who I'm now going to introduce. I'm going to start with Dr. Ruzek. So Dr. Michael Ruzek is a board certified emergency physician. He serves as the president of the New Jersey American College of Emergency Physicians. He also currently serves as the medical director in the Department of Emergency Medicine at Capital Health Systems, as well as leads quality and patient safety initiatives system-wide for emergency services. We're all over the place all the time, emergency physicians doing it. Dr. Ruzek is an assistant clinical professor at the Rowan School of Osteopathic Medicine and the Philadelphia College of Osteopathic Medicine. He has served in the past on the National ACEP Steering Committee, as well as chair of the YPS section. So welcome, Dr. Ruzek. Thank you.
Thank you, Dr. Terry. Thank you.
Absolutely. And Dr. John R. Corker, MD, FACEP, is a partner with his independent democratic group, EM Specialists, practicing community and academic emergency medicine in Southwest Ohio. He is a past chair of our ACEP Young Physicians section and has served on the ACEP Federal Government Affairs Committee, the Strategic Planning and Reproductive Health Task Force, as well as Ohio ACEP's Government Affairs Committee. He completed his health policy fellowship with the American Medical Association in 2013 and continues to hold numerous leadership positions in organized medicine at the national, state, and local levels. His award-winning medical talk show, Radio Rounds, inspired our very own EMRAcast and the YPS EM Lifers series. In 2021, Dr. Corker was named as one of EMRA's 25 under 45 influencers in emergency medicine. And in 2022, he was recognized by the ACEP 911 Advocacy Network as their Member of the Year. Welcome, Dr. Corker.
Thank you, Dr. Terry. It's a privilege to be here with you and all of our fellow EM specialists today.
Absolutely. Well, let's dive right in. I actually want to hear from both Dr. Corker as well as Dr. Ruzek. They're going to start with some opening comments.
Well, thank you, Dr. Terry. It's a privilege to be here with you all. My name is Dr. Michael Ruzek. I am a board certified emergency physician. And, the reason that we are all here and having this discussion is because we have one thing in common. We all care about emergency medicine. I have been a member of ACEP since residency. I started as an EMRA member and I continued as an attending as a member of ACEP. And the reason I did so is because I care about the specialty of emergency medicine and have seen the work firsthand that ACEP has done to represent emergency physicians. I want to start by stepping back, and we also always refer to ACEP as, this entity, but what is ACEP in reality? ACEP is us. ACEP is comprised of 40,000 emergency physicians. We are ACEP. ACEP is not separate from emergency physicians. And I've seen firsthand as a chapter president, the political advocacy that we do here in the state of New Jersey, and each emergency physician does in their own respective states. The importance of the fact that really representing our specialty starts at the grassroots, as the challenges we face as emergency physicians may be unique to the geography in which we practice. But having an overarching lead such as ACEP and the political advocacy calls that we utilize ACEP and organize with ACEP and have resources with our national college in order to fight for the autonomy of emergency physicians in order to fight for the fair reimbursement of emergency physicians. At the end of the day, even though as individuals, as various emergency organizations, we might have different approaches in how we advocate for our specialty, we have a common bond together. And our intention is to advance emergency medicine and protect the rights and autonomy of emergency physicians. And I think as long as we are unified and having honest and transparent conversation, I am confident that we shall prevail and protect the specialty of emergency medicine and protect the autonomy of emergency physicians and see our specialty continue to grow and thrive. Thank you, Dr. Terry.
Excellent, excellent. Thank you so much for those inspiring words and certainly for your experience, not just clinically as a medical director and the like, but certainly in terms of leadership with New Jersey ACEP, one of our 53 amazing chapters. And so thank you again for those opening comments, Dr. Ruzek. Dr. Corker.
Yes, thank you. And again, to everybody who's taking time out of their busy schedule today to join us, we just really appreciate you because as I tell my residents and my colleagues and even my patients, I'm an open book and I'm really happy to be part of this ACEP gesture to espouse that same quality. Ultimately, I realized early on in my medical career, as early as medical school, that physicians, not just emergency physicians, don't really have many friends out there, whether it's the government setting up field offices in our exam rooms, whether it's large insurance refusing to pay for the care that we provide, whether it is non-physicians seeking the independent practice of medicine and kind of threatening and violating the sanctity of the physician-patient relationship and the physician-led care team. What I found out early through my involvement with EMRA is that we need unified voices and unification organizations for all of us as physicians and specifically for us as emergency physicians. And when I got involved with EMRA as a medical student, I really met a lot of interesting people, created a network. Although this is, of course, unofficial, I would argue that all the people that I met as a medical student through EMRA, when I went to away rotations and interviews, I always knew somebody, always knew someone with a common interest and a common background. And that networking and those relationships mean a lot through your career. I've also had the opportunity through my involvement with ACEP to sit down with members of Congress, whether it's Democrats with Ami Bera or Raul Ruiz or Republicans with Brad Wenstrup and Dr. Larry Bouchon, all four of whom are doctors. We've had an opportunity to sit down one-on-one and talk about our most imperative legislative priorities as an organization to move forward our specialty in a way that allows us to practice medicine in the way that we were trained. Because ultimately, whether we know about it or not, whether we're aware of it or even agree with it, there's decisions made every single day by non-physicians about how we are allowed to care for our patients. And it's critically important that we take a seat at those decision-making tables. ACEP, as the unifying voice for emergency physicians across the country, has the seat for us at those tables. And as a member, we have an opportunity to move forward and take that seat at the table and have a real impact on the decisions that are being made about our patients and our ability to care for them. So today, as we go through all these tough questions with tough answers, I hope everybody will be open with their questions. We'll certainly be open with our answers because I truly believe in my heart that my membership in ACEP provides value to me far and above the dollar figure that I contribute each year.
Thank you so much, Dr. Corker. Very well said. And actually, your comments make a really nice segue to the first question I actually want to ask you. And just so you all know, we have been soliciting questions and have actually received several questions, and we're going to try to get to as many as we can here. And as Ms. Nelson said at the beginning, if you have any questions, feel free to put them into the chat as well, and we'll get to as many as we can. But I want to start by just having you elaborate a little bit further, Dr. Corker, on the value of ACEP in terms of ACEP membership. We pay certainly ACEP dues each year, and some may argue that it's too expensive and that it's not worth the dollar. What are your thoughts in terms of the value of ACEP membership and all that it brings?
Sure, and that's a really good question, and ultimately the biggest question and the first question that I get whenever I'm talking to my colleagues about joining ACEP because the bottom line is we work hard for our money and all of our dollars count. And while ACEP's membership dues are very much in line with the yearly membership dues of any other professional organization or specifically membership organization for physicians, I think it's important that we're able to communicate the value that those dollars provide and what they go towards. As I mentioned before, as emergency physicians, we don't have that many friends out there. Well, ACEP is our friend and in some ways, even our family, and can provide that community for us in an increasingly divided world that we practice in. As I mentioned before, I'm a past chair of the ACEP Young Physician section. And the Young Physician section in ACEP is actually the largest section of involvement within ACEP, thousands of members across the country. And since its inception many years ago, it's become one of the most vocal sections as well. And we have an opportunity as young physicians who are just starting practice have our own unique kind of interests and challenges, making decisions about families and home ownership, paying back loans, having delayed our lives compared to our non-physician peers, sometimes for as much as a decade. The Young Physician section has provided me an opportunity to get together with other young physicians, educate them on particular topics. That's how we came up with our EM Lifers webcast series, where we've had the White Coat Investor on to talk to us about early career financial planning. We've talked about contracting. We've talked about the different employer models. And when the ACEP workforce study came out a few years ago, what it would mean for our specialty and for med students and residents, what will it mean for them for opportunities moving forward. But we've had incredible engagement with these types of educational opportunities through YPS. And as a larger ACEP, they provide hundreds of hours of CME each year, which is easily accessible. And ultimately, it starts with our in-person scientific assembly every year in a new fun city where we can get together and share war stories with colleagues when sometimes it can feel isolating, especially with those of us who sometimes work single coverage in freestanding emergency departments. But of course, I think it's also important to recognize that ACEP is the only emergency medicine representative organization as our unified voice that has full-time staff in a dedicated office in Washington, D.C. that represents our interests every time a piece of healthcare legislation crosses the floor of the House or the Senate, and then provides support for all of our state ACEP chapters who are also working hard for us in our state capitals across the country. So as we battle the very real challenges of scope creep, seeking independent practice of medicine by non-physicians, as we battle challenges to getting paid for the services that we provide. You see, we're all aware of our merit badge or of our badge of honor of EMTALA, the unfunded federal mandate that says we have to provide our professional services without any indication or any expectation of being paid for those services. We're the only professionals in America who are federally required to do that. And we wear that as a badge of honor. But on top of that, we have insurance companies pushing us out of network, naming an entire piece of legislation a No Surprises Act, which is insurance offered language, when in fact it's out of network billing, not surprise billing. The results of these bills are from narrow networks. As insurance companies continue to not pay for the care that we provide, ACEP is there with our team of lawyers, our team of lobbyists, all of which have salaries, and all of our wonderful staff for these different sections in National ACEP. That's what our dues money goes towards, ultimately providing our only friends and our only family in an increasing divided world.
Thank you so much for those comments. Really appreciate that. So let's talk a little bit, let's go a little deeper. You talked about, Dr. Corker, how busy ACEP is doing multiple things, how we have a very well-equipped staff, really in two different cities, in Dallas as well as Washington, D.C. But what exactly are we doing around some of these specific issues? Let's go a little bit deeper. So let's start by talking a little bit about workforce. We actually received some questions relative to, one, the increasing number of residency programs that we're seeing and what ACEP thinks about that. What is ACEP doing about that? Certainly, we received some questions about how to reach younger generations and to ensure really the future of the specialty and the workforce. And a lot of this is around the backdrop of, a workforce study that was published around 2021 that was a prediction that there might be a surplus going forward by 2030, but also on the backdrop of the fact that this year's match was certainly disappointing in terms of the unfill rate, something that has not been the case for emergency medicine historically, really ever, and had about an 18% unfilled rate. And so, in terms of how ACEP has really approached the issue of workforce, it's been multifactorial. Actually, well before this year's match, ACEP has been working really hard around several pillars of approaching the workforce issue. A big part of that has to do with taking a look at residency standards. For emergency medicine, we actually have not updated the requirements for residency training in some time. It's something that ACGME does about every 10 years. And so ACEP actually put together a work group that actually met every 2 weeks for over a year in order to submit some ideas and recommendations to ACGME relative to the training of emergency medicine residents. And we know that certainly that impacts ultimately workforce. It certainly impacts residency programs and their approval, et cetera, and their sustainability. And so we actually submitted, again, a pretty comprehensive set of recommendations to ACGME, and we were very grateful that they invited ACEP in, actually, to share our thoughts with them. And it's been received, and we know that it's going to be several months before a new plan is released for emergency medicine residency training by ACGME. But it's good to know that, after consulting our members and other emergency physicians, we actually gave several recommendations to ACGME around a number of required procedures, for example, number of requirements relative to volume of patients that you're actually seeing, around issues related to core faculty and who should be core faculty and what the protections for core faculty should be. So there's more to come there for sure. We also have been in conversation with several organizations and groups that may have or own residency programs in the country. Honestly, our thing is that we want to have conversations with the groups that are contributing to the 30% increase in residency programs that we've seen over the past 5 years, regardless of who they are, honestly, whether they're public, whether they're private, or whether they're universities. And I can tell you there's a mix of groups that are involved with having increasing sponsorship of residency programs. And so we have actually taken the initiative to reach out individually to several of these entities. One, to make sure they're aware of what's going on and how, the increasing number actually is impacting emergency care and impacting our workforce and the like. And so we continue to have those conversations and we'll hope that, our suggestions, our thoughts, our enlightenment will actually impact and hopefully slow down really the growth in terms of number of residency programs, because no doubt that certainly impacted the unfill rate that we saw this year. So any other comments relative to workforce that you might add, Dr. Corker or Dr. Ruzek?
I think you said it very well, Dr. Terry and Dr. Corker. And I think, workforce issues, as they are specific and vary from state to state, there is an overlying arching theme throughout the country. And as much as, statewide, we would like to advocate for better working conditions for our physicians and emergency physicians. We require the data to demonstrate such and to really back what we say, so it's not just a subjective opinion. What ACEP has done is really done the hard work, heavy lifting for us. They've invested in the research, invested in the studies, invested the time and energy of experts, and combined the expertise of emergency physicians throughout the country to look at the issues and topics at hand. Now, I hear a lot of emergency physicians that are going through some of the challenges that we face in emergency medicine today. And, they want this problem solved yesterday. And I could feel their pain and I could feel their sentiments. But again, the fact is that growth and development and change does take time. And I think it should not go unrecognized. The fact that ACEP, as a community of emergency physicians, has heard our emergency physicians, understands and is willing, ready, and able, and has demonstrated its ability to invest the time, energy, money, commitment in order to address these issues. And there are there are things that are within our abilities to change, and there are things without outside our abilities to change. But again, as long as we stay on the path, and as long as we stay consistent to addressing these workforce issues, I think we will ultimately be successful. And furthermore, from workforce, it's physician reimbursement. ACEP has protected physician reimbursement time and time again, and this affects each and every physician's ability to put food on the table for themselves and their family. And there is nothing wrong with being an emergency physician and asking to be fairly compensated for the work and care that we provide day in and day out. There is nothing shameful about that. And ACEP is the sole entity that represents emergency physicians to the RUC. And for those of you that are on this call that don't know what the RUC is, it is an voluntary advisory committee to Medicare that advises Medicare about physician reimbursement. And I've seen firsthand, time and time again, you don't the pay cuts that ACEP's work on the RUC have prevented. Sometimes you don't think about it, or you don't know about it, or you haven't been told about it. But this is real time dollars that are put in each and every single one of our paychecks due to the work that ACEP has done to advocate on our behalf. And these are real time changes. And the fact that I respect ACEP for the fact that over the past year, their legislative and interventions and their interventions in a legal aspect to advocate on behalf of emergency physicians increased by 400%. So for those efforts to increase by 400% in a single year gives me reassurance that my college hears me and is doing something about my concerns and the concerns of our colleagues. This doesn't happen by coincidence. The fact that ACEP has filed 9 amicus briefs over a brief period of time in order to protect physician autonomy tells me, hey, Mike, we hear you loud and clear, and you're not in this fight alone. We're there with you. We're there by your side. And as emergency physicians, as long as we're having these tough discussions, whether we agree on how we approach some of these challenges or disagree, I think we're going to have a positive outcome. I welcome you all to come to an ACEP council meeting if you've never attended. And I'll tell you, at ACEP council meetings, there is live debate that is very passionate at times, but the decisions made in ACEP are made by emergency physicians that come out and sometimes disagree on things and agree on other things, and at the end of the day, do what's best for our college and our specialty. And I thank you for that, Dr. Terry.
Oh, well, I don't know if you can thank me directly. Certainly, we're in this all together, but no doubt about it. You bring up really excellent points around reimbursement and how, every single year we are fighting against, cuts. And I think that oftentimes physicians aren't even aware of the many cuts that are diverted, that you don't even have to deal with because of the work of organized medicine and groups like the American College of Emergency Physicians. So thank you so much for sharing that for sure. I think that when we talk about again these challenges, one that we haven't mentioned so far, we've talked about workforce, we've talked about reimbursement issues, and a lot of it is all very much related. But one issue that we have seen a tremendous increase in over the past few years is boarding in our emergency departments. So I want to talk a little bit about boarding and would love to hear some insights from both Dr. Corker as well as Dr. Ruzek in terms of how to deal with boarding in your emergency departments on the ground. It certainly increases the chances of there being workplace violence. It increases certainly frustrations. It delays care. And in general, just doesn't make it, a really awesome place to be in, frankly, whether you're the physician or the patient, when there's just languishing in the emergency department, and people feel like there's nowhere for them to go, and they're not being cared for properly. I will tell you that from a policy and advocacy standpoint, ACEP has really taken on boarding significantly this year. Put a lot of efforts into raising awareness around boarding and what it is, in terms of essentially patients being admitted to the hospital, but staying in the ED rather than going to their inpatient bed or being transferred out, for that matter. We actually had collected several stories from emergency physicians all over the country about their experiences with boarding in their emergency departments. And we put together this letter with stories, anecdotal, but certainly very touching and very real. And we actually sent it to the White House. We were able to get over 40 signatures from congressmen and women on this letter. We were able to get co-sponsorship with other organizations. And we sent that to the White House. And our ask was that, one, you recognize that really there's another public health emergency happening right now, every day in our emergency departments, where people are unnecessarily dying because of boarding in the emergency department and certainly not getting the care that they need. And we are asking the White House to actually sponsor a summit of various stakeholders to, again, increase awareness about the problem and come to the table and talk about how we can have solutions. I think too often emergency physicians are kind of blamed for some of the things that happen in the ED, because essentially the ED is a place where a lot of the symptoms of bigger systematic problems show up. But the reality is that boarding really has to be a collective and collaborative effort in terms of ending it. It can't just be emergency medicine. It has to be the hospital. It has to be the community. It has to be certainly our policymakers. And so we are still pushing that agenda with the White House. We actually did have a meeting. ACEP leadership had a meeting with some of the leadership in the White House about the topic. And we're going to continue to push the issue. We also just recently, we were able to land a congressional briefing in DC, actually next week, I believe, with Congress to, again, increase awareness around boarding and what it is and why it is incredibly detrimental to the safety net of healthcare in this country. So that's another piece in terms of work that we're doing around boarding. And we're also assisting chapters at the state level around their individual efforts in terms of being able to start the discussion, the dialogue, the conversation with the governors of various states and their various legislators at the state level as well. So we will continue to push for that, because we know that boarding is just one of the issues that we're facing that makes it really tough to do our job. But I'd love to hear from Dr. Corker. I guess if you could start with this answer. In terms of some on the ground remedies or ways that you have found to be very helpful relative to managing boarding in the ED.
Sure. Thank you for kicking it to me. And with respect and humility, I do have a few comments on boarding, but I'm going to eventually kick it to Dr. Ruzek as a medical director. I am not in as high a position as he is to have dealt with this structurally in my hospital as he has. But before I kick it to Dr. Ruzek, I did want to mention and certainly amplify Dr. Terry's comments about what ACEP is doing at the national level to make people aware of the public health crisis that is boarding, of its multifactorial nature and causes, and advocate for as high as the White House to discuss this issue, and then legislation to increase funding for things like increased transport to get our nursing home patients back home once we've discharged them, to increase funding for social workers to help get mental health patients where they need to be, to increase funding for mental health and drug addiction beds so we can get patients who are medically cleared but in need of further care where they need to be, all addressing the very real contributing factors to boarding. Honestly, one of the biggest factors in ED boarding is a lack of nursing coverage for inpatient beds. So advocating for legislation for more funding for nurses and nurse training on the floor so more beds can be opened. Sometimes people say it's not a lack of beds, it's a lack of staffed beds. And so ACEP has really thought outside the box as it regards to all the different many factors that go into ED boarding, and are advocating for you at the state and national levels to secure funding to reduce the burden on our physicians. But I think just as importantly, ultimately, boarding has resulted in very real and dangerous situations, not just for our patients, but for our physicians. When our physicians have whistleblown for bad institutional policies leading to ED boarding, or God forbid, a bad outcome for a patient that's directly stemmed from ED boarding. Some of our physicians members who are employees of perhaps third-party organizations or employees of the hospital haven't received the due process that they deserve and have been, quite frankly, fired or put on leave because of attracting attention to this public health crisis. And ACEP has really taken an incredibly strong stance in support of our members who have suffered from a lack of due process. First of all, our policy compendium has significant policy voted upon by our membership in support of our members to ensure that due process is afforded to every emergency physician in any sort of contract or employment dispute. We have also worked with Representatives Berra and Raul Ruiz to secure legislation at the national level to codify this due process for all physicians and emergency physicians who face these situations. I actually have a bill number here. I wrote it down as I was taking notes, but we worked directly with Dr. Ruiz to develop HR 6910. It was a bill to ensure these due process for all physicians, and we are still working with these members of Congress to get this passed, to make sure that when our physician members are doing their job to address the effects of boarding in real time, while Congress gets their act together and addresses the underlying causes, that we are taking the most aggressive stance as an organization in favor of our physicians. But as regards what kind of individual facilities are doing to address boarding, I'm going to defer to the illustrious Dr. Ruzek.
That's very kind of you and very well said, Dr. Corker. And I'm just going to go ahead and reiterate, your very insightful words, Dr. Corker. Boarding is a multi-aspect challenge. And what I mean by that is, there's boarding for multiple reasons. And as you insightfully mentioned, sometimes it is not due to a lack of beds. It is due to a lack of staffed beds. So it's very important in addressing the boarding issues to make sure that we also look at it from why the boarding occurs. Many times due to nursing shortages, while there is physical space on the floors, those beds aren't available due to the lack of staff nurses. Now, another reason when there is actual physical space on the floors and there are, actual nurse staffing on the floors, and that isn't the issue. The issue is due to lack of physical space. What we have seen emergency departments and ACEP successfully advocate for is sharing those inpatient resources with the emergency department. And a lot of health systems we have had the conversations with, well, while the emergency department is a dynamic, ever-changing environment, the inpatient is a more controlled environment, yet we rarely see boarding on floors. Yet it is allowed, and there's a double standard where boarding is allowed in the emergency department. Some solutions have been having holding areas, extensions of waiting rooms, observation areas. And we have shown that when those holding areas and observation areas are staffed by emergency physicians, there is a continuity of care there. There is a better turnaround time there. There are less consults there, and it's a less cost for the system, and it's better outcomes for our patients. Now, that being said, looking at all those aspects, is boarding still going to be a reality that we deal with and ACEP is going to continue to advocate for? Yes. Now what? If we're already doing the work, one of my colleagues in emergency medicine, who I see as a mentor, shared some insightful knowledge and information with me. He said, Michael, when we first dealt with urgent cares, we said, we don't want to deal with runny noses. I did not practice to be an emergency physician to deal with runny noses. And we didn't really own urgent cares. We just let it be. Family medicine physicians got into there. Multiple other specialties got into urgent cares as well as emergency physicians. And that cat is really out of the bag. But there was a time that we could have owned the urgent care equation and aspect of delivering care through urgent cares. But we let that go. When strokes and delivering TPA first came on the scene in the emergency departments, we let the neurologists deal with that and make that decision in the emergency department, where emergency medicine physicians make much more difficult questions day in and day out. Well, you know, another aspect is emergency physicians are going to deal with sporting. Maybe there's a discussion that they should be reimbursed for it and have a portion of the hospital fees if they're actually doing the work. If we're going to own it, then let us own it in all aspects of it and give us the resources to own it. So that is another way that we could reapproach the conversation. If we're going to do the work regardless, then maybe the emergency department deserves a portion of the inpatient hospital fees. So, this is a dynamic question. That boarding is occurs for many reasons based on the hospital systems and the realities of on the ground of where we are. And this is a conversation that ACEP has recognized is important to the practice of emergency medicine and patient safety, and it's a conversation that we're going to continue to have.
Absolutely. Excellent, excellent points. Thank you so much, both of you. Well, we have about 15 minutes left, and I definitely want to get to some questions from the audience. And so I am going to actually defer to Ms. Nelson. Any questions for us that we may take?
Okay. We have a question. It says, what does ACEP think about the practice of having a friendly physician-owned EM practices on paper while selling and signing away all real ownership rights to non-physician-owned consolidators? Does this structure violate corporate practice of medicine laws? Should ACEP censure such friendly physicians if they are members of ACEP?
Yeah. So that's a loaded question, several parts to it, but certainly a very important one. And so we appreciate the person who asked that question. I think that in terms of physician ownership of hospitals and of practices, it's interesting because I was just actually representing ACEP at Docs on the Hill Day in DC, I guess a couple weeks ago now. And there was a lot of discussion around a movement for physicians to regain autonomy in terms of ownership. There's definitely been a shift away from that physician ownership. And in fact, it's actually illegal for a physician to own a hospital. Interestingly, nurses can apparently own hospitals, however. And so there is some legislative work going on around that topic. And certainly ACEP was in DC when these discussions were being had, and emergency medicine's role relative to it was also discussed. In terms of the corporate practice of medicine or corporatization, ACEP has been very clear on the fact that transparency is incredibly important, and that relative to corporatization, there should absolutely not be loss of the physician-patient relationship. And we know that sometimes that is the outcome of some corporatization and the like. The board actually reaffirmed, actually didn't reaffirm, but started a new statement around specifically corporatization and private equity, and released a statement on that April of 2022. And again, it just emphasizes the importance of the physician autonomy and the importance of making sure that physicians are able to practice and care for their patients in the way that they deem best. I think that in addition to our individual statements, like I just mentioned, certainly we again are on Capitol Hill, as I was 2 weeks ago, having these discussions with fellow physicians as well as legislators in terms of how to, on a grander scale, so have policies and advocacy to ensure the protections of the emergency physician. In terms of censorship, ACEP definitely, primarily, most of our censorship activity has been around looking at, physicians who may not adhere to ACEP policy relative to testimony and like, and certainly causing harm to fellow ACEP members and the like by way of such behaviors. And so censorship is definitely something that ACEP does. But in terms of, censoring, more like corporate entities and the like. Certainly, that's not an area that we've been involved with, but I do think that it's important to recognize that ACEP policies serve as a conduit to really help to ensure that behaviors are appropriate and to at least have something that's in writing around what the American College of Emergency Physicians feels relative to these various topics. So that's an excellent question. Thank you for that.
Okay, we have another question here that says, the reality is NPs and PAs will have independent practice authority in all states. Do you think that physicians and ACEP will take a firmer, more aggressive stance against this?
Dr. Corker, you want to take that?
Sure. Yeah, and it's a really good question. At the end of the day, as we know, the sanctity of the physician-patient relationship and physician-led care teams and protecting that sanctity is one of the highest goals and the highest priorities of ACEP. It's interesting. A lot of people point out that NPs and PAs have achieved some independent practice authority in a significant number of states. I think one thing that ACEP has not advertised well enough is that we have actually helped defeat more scope bills or independent practice bills across the nation than have passed. We have continued to work behind the scenes in every state from coast to coast to work against and provide our significant resources to work against any bill that would promote non-physician-led care or the independent practice of medicine from people who are, quite frankly, not trained to practice independently. That said, ACEP has also thought outside the box in determining we need to own this particular topic, and we need to define what meaningful supervision is. That's a topic that hadn't been previously defined, and one that ACEP continues to work on defining in a way that is reproducible across the country. And then, of course, one of the realities is that in the current care models and in our with workforce shortages and healthcare deserts across the country, NPs and PAs have become helpful members of the physician-led care team across the country. And one of the things that ACEP is looking at right now is how do we better define and organize training in a way that says, hey, if you're going to work on our physician-led team, this is the very specific, very organized, very regulated training that needs to be had for that to be the case. But I don't want people to mistake ACEP's kind of ownership of the physician-led team and defining what that means, what supervision and what proper training is needed, not just for our residents, but for all members of the team, with a lack of focus on fighting against the independent practice of medicine by non-physicians, because ACEP has a clear stance against any violation of the physician-led care team, and we have helped defeat more scope bills across the country than have passed. And I think that's a really important point.
Yeah, absolutely. No, I appreciate the comments and the question. I think the question was worded, when will ACEP take a firmer stance? And I think to Dr. Corker's point, we probably should advertise more of what we are actually doing. In terms of scope, I'll say that just last year, the work that ACEP has been doing around scope creep was actually recognized by the AMA, such that we were invited to actually lead a discussion at last year's AMA meeting relative to scope. We know that certainly emergency medicine is, again, pretty vulnerable when it comes to issues related to non-physician providers and the like. One of the key pieces is that we need data and we need to use our quality metrics, for example, to really show that physician-led care is actually superior to care led by a non-physician. We are having increasing data around that. There's a study out of Stanford that came out last year that actually showed that readmission rates as well as costs has significantly increased when care is led by just independently by a nurse practitioner. And that study was actually led by one of our own, an emergency physician through the VA health system. And so we're looking for more and more certainly data there. ACEP continues to partner with the AMA, which has done a lot of work in terms of this area relative to dispelling the myths that, for example, NPs and PAs tend to practice more in undesirable areas like rural settings and the like. That's actually just not true. And also myths such as that they are overall can be cheaper, if you will. But the fact is that more and more data is showing that due to increased testing that they may perform, et cetera, that ultimately the cost could be actually more so in turn on the system. And so we will certainly continue to fight scope creep federally as well as helping our state chapters. And really we should do more publicity in terms of sharing with you all what we're doing in that regard. Oh, and one more thing you should know, we meet with SIMPA all the time. We meet with our NP colleagues all the time. When I say all the time, at least a few times a year, we have meetings and discuss these issues. We're very clear on where we stand in terms of wanting to protect the physician-led team.
I'm going to combine a few questions because we are running tight on time, but we have a few that had to do with just the challenge of the rhetoric on social media, some of the false narratives that have to do with not just EM but also ACEP. The narrative that ACEP is influenced by private equity. So I'm kind of combining all of that just into one topic so we can at least address it before we run out of time.
So let's start with the question around SOMI and social media. Dr. Corker, you want to start with that one?
Well, I mean, at the end of the day, social media it can be a great tool and it can be a place where things go off the rails. But I will say from an ACEP perspective, what we try to focus on is putting our best foot forward and making sure all of our interaction on public forums is fact-based and based in our significant concern for all emergency physicians, not just ACEP members. Because at the end of the day, as I mentioned before, ACEP is kind of a welcoming home for all emergency physicians. We are the unified voice, and honestly, our council is the House of Emergency Medicine, creating our policy, democratically voted upon by all those emergency physicians who choose to participate. So as we move forward, representing as many emergency physicians as show up and participate, we want to make sure that we continue to take that leadership role very seriously and to engage in all of our discussions publicly in a way that's positive and productive.
Indeed. Anything to add to that, Dr. Ruzek?
No, at the end of the day, it's important that regardless of our views as emergency physicians on how to approach it, to understand that we need to step back and not be divisive as a specialty, but supportive of one another. We all care about emergency medicine. I think it's important to recognize that. And I think unfairly critiquing one organization or another serves really no one's interests at the end of the day. ACEP supports emergency physicians regardless of who you're employed by. We are not going to turn our back on a single emergency physician based on who their employer is. And at the end of the day, it is an organization that exists for the protections and advocacy of emergency physicians. And it is what is ACEP composed of at the end of the day. I think as long as we keep the rhetoric with the sole purpose of advancing emergency medicine and not the fact that we are in competition with each other, it's okay to disagree, but at the end of the day, respectfully disagree. And as we remain a house united to advance emergency medicine, regardless of what flag you fly under, I think emergency medicine will always be in a better place. We showed up because we care. And sometimes we have heated discussions because we care. But we need to be allies and advocates to one another at the end of the day, because we're all trying to get to the same place of providing the best emergency care for our patients and protecting the autonomy of the specialty we love so very much.
Absolutely. Very well said. Thank you so much. And I'll just add a quick comment as well. I think I'm in DC, so I practice at George Washington University, and I'm one of the advisors on our health policy fellowship and have been for years. And I can tell you that when we go to the Hill, congressmen and women are not asking, are you a part of ACEP or AAM or any other organization? They want to know, Are you an emergency physician, and are you representing the specialty of emergency physician? And so, there really just is not there's no time really. We have too many important issues to deal with to have, internal divisions, as has been said. And certainly social media can contribute to those divisions. I think that one solution is to be very proactive, first of all, in our messaging rather than reactive. To again share all of the wonderful things that are being done, and to not be negative. And I also think that we have to try to bridge gaps. We have to try to find common ground, and certainly there's plenty of that. There are plenty of things that we do agree on, and I think that it's very important to focus on those things that we do agree on. And I think the thing that we agree on most is that emergency medicine is an amazing specialty, that really deserves and has to survive in a way that continues to support the safety net of our country. And so, to that end, we have to come together and put our differences aside, and focus on, what really brought us into the specialty to begin with. So, with that, I don't know if we have time for one more question, Jana. Actually, Dr. Corker had one.
Yeah. So we had a very straightforward question in the chat. We talked before about how ACEP is working with the ACGME to try and address the supply side of the supply and demand conundrum that underlies our workforce issues. And as ACEP continues to work with our recommendations to codify and promote competencies and minimum level of training that we want for all of our residents, once we get to that final product, will that be published for all to view, what we work with the ACGME on?
Yeah, absolutely. Excellent question. So what we submitted is not, available to be shared at this point, but absolutely once the final product is done, it absolutely will be published for all to view. All right. Well, Dr. Corker?
Yeah, I just wanted to let everybody know that we do intend for this to be an ongoing series and an ongoing conversation. So as you come up with questions in the coming days and weeks, months, really whenever anything comes up, reach out to us, whether it's on our social media or through our website. And I know Jana has a little bit more, one of our staff members has a little bit more information on ways you can tag these posts or these questions so that they get answered in a timely fashion. But I want everybody to know that we don't mean for this to be a one-time thing. We are, we're the life-saving specialists. We just know the second most about everything else. We're really good at multitasking, and every day brings a new challenge. So as you encounter those challenges, please remember that we're here for you as an organization, and we hope that this conversation will continue to be ongoing.
100%. Thank you so much. Thank you all. Have a great evening.